Thank you, sir. Thank you for having us. Like he said, I'm Wayne. I'm the Deputy Executive Director with the Board of EMS. Haven't been there very long. As you all know, as we start to get through, the Board of EMS has been rather hectic in the last couple of years. But I think we're starting to prod our way out of the holes that we were in. Or so. So what we're going to look at is we're just going to do an overview. The big thing that I think Dr. Lubbers wanted us to hit on is probably looking at some past regulation that has changed over the years, pending state regulation and statute that's currently in the hopper that's going through. We're going to look at what type of goals and our future looks at in the next couple of months to a year. And then we're going to talk about the EMS reassessment that that the state went through in late 2024. So it cut off part of my ranking, but as you know, the Kentucky Board of EMS was reorganized again, looking like on the third or fourth time since its inception. We're now back under general government cabinet, and we're an independent board, and we're overseen by a board of 13 representatives from across the Commonwealth. And as you can see, they represent a pretty broad spectrum of providers in the medical field. But we got John Holder as the board chair, Keith Smith out of Louisville is our vice chair, David Webb, Donovan Blackburn, Mr. Edmondson, Dr. Crafton sits on our board. I will point out that we have a physician for children that oversee emergency care for children vacant. It's been vacant for some time, probably close to a year. Getting board appointments is difficult, but I believe that as the American College of Physicians, you all at some point have the appointing authority to recommend 3 names. I don't know that that's been done. There seems to be a little bit of confusion. So if you know someone in the pediatric emergency care that would like to fulfill this position, reach out to us so we can start getting this position filled, because it's not good not having all 13 members on the board. So if you know someone, reach out to myself, reach out to Dr. Lubbers so we can get this position filled. Christopher Hawkins is a paramedic educator out of Louisville. Mayor Kevin Cotton was recently appointed out of the Madisonville area as a mayor representative. Harry Clark is a county judge in Moorhead. Ben Neal represents out of Louisville, and then Tim Webster out of Northern Kentucky. And that's your board. And if you've got problems and you really want to dive into change in the Commonwealth, you need to reach out to the board members, because they help drive and make the final decisions on where we go strategically through regulation and statute. So when we look at some of the past changes, some of the bigger things that's happened over the last couple of years is we talk about statute, and we established an EMS grant program last year. Unfortunately, it didn't get funded, but when we looked at what some of our big stakeholder problems was workforce. And the biggest workforce problems that we identified with education was cost for tuition, being able to get the student off work in order to go to the paramedic programs, and then just the number of pure education infrastructures in the Commonwealth to begin with. And that's what that grant program addresses. It provides tuition reimbursement to the student. It'll provide cost reimbursement to the agency to offset personnel cost, and it allows us to fund out and establish new training and education institutes throughout the Commonwealth. Unfortunately, I don't know if you don't deal much with statute and legislators, they did not fund it. We were looking for about a $6 million upfront push in the biennium budget, and we didn't get it. We'll go back in 2026 fighting for those dollars to try to get this program up and running. I think it'll be a significant impact. We changed licensing agency classifications, and we removed that out of statute, and we want to push it all to regulation. And we pushed it all to regulation because regulation is so much easier to change than statute. You've only got a small window to change a lot of statute. And from previous changes, we needed to readdress how we license the agencies in the Commonwealth. And that's what 545 did. We changed reciprocity language last year as well. We removed we used to only do national registry only. And then there was a change that said, well, if you're a contiguous state, and now the most recent language is if you're licensed in another state, in good standing, we're going to allow you to come into the Commonwealth, hit our education courses that you need to do that's specific to Kentucky, and we're going to license you. We're trying to pull in a workforce, and that's why we're trying to tackle some of that. One of the next bigger items was the termination of death. They've removed the termination of death out of statute, and it was real tricky. It's real confusing, but when you look at how most agencies across the Commonwealth function, we really never did determine death and sign death certificates. It was all really kind of driven towards determining non-viability. So we removed that determination of death and we pushed it all to local protocol and state protocol oversight and determine who's viable and who's not. It's still the coroner's position to determine death and sign the death certificates. Then we kind of dive into the regulation side of things. You know, if you've not really looked into the past, there was a fee reg change that increased fees, but what it did is it provided initial licensing for new individuals for free. So all you new paramedics coming in the next little bit, you're all going to get licensed for free. And they kind of shifted and made some different changes across the spectrum of agencies. So a little cost shift there. Again, they're really focusing in on trying to get a workforce up and going. And they made some changes in renewals, especially for educators. You no longer have to pay $150 some odd re-licensing fee if you're an educator. We're giving you the credit for being an educator and licensing your primary license at no cost to you. We made some technical corrections. Like we said, we talked about reciprocity. So anytime you see a statute change, we've got to go into a regulation and make conforming language changes. And when you look at the 201, 301, and 330, those are all provider-specific regulation changes into the EMR, EMT, and advanced EMT. And we've just made reciprocity language change. The 401 paramedic got a little bit more complicated. Like we said, we did the reciprocity language. We conformed the determination of death, the non-viability language, taking out the determination of death course and striking the protocol specifics. Because again, in talking with Dr. Lubbers, and it's just easier for the local agency to determine non-viability than it is for us. But one big thing that is important, and especially for the medical directors and agency directors, is the critical care endorsement. That's probably gotten more debate and discussion over the last 6 months than anything across that we've done. But what as you'll see in the next little bit is we're transitioning from an endorsement to an advanced practice paramedic provider licensure. So in 2026 or 2025, as it's slated to go, and again, this regulation is still in legislation trying to go through its codification. In 6/30 of 25, the board will no longer license or issue board endorsements. We're going to cut that off because we're going to start making that transition to the advanced practice paramedic licensure. And then they will be able to function if you've currently got it until January 1 of 27. After January 1 of 27, anybody that's wanting to function in the advanced practice scope of care will have to be an advanced practice licensed paramedic. There will not be recognized any other endorsements. So they will sunset in 2027. And we're originally talked about in 26, but as things have kind of slowed down in 25, we decided it's best to push it out another year and make sure that we're trying to get everyone transitioned correctly. So that portion is really important if you're functioning with the advanced scope of practice model things currently. So make sure you take note of that and go back to your services and start making plans. I know we've had some discussions with Air Medical. There's some concerns there, but we think we're given a pretty decent 2-year window to get all these people transitioned and develop a plan so that you don't have service interruption. Over the 550 regulation that sets out all your equipment standards that you're supposed to carry, whether you're BLS, ALS, neonatal specialty care. everything outside of the air medical service. They updated the equipment standards in 23, I believe, early 24. Those will be coming back up. The 560, that was a recently emergency regulation done, and that's our staffing level. And if you've watched across the United States and in Kentucky specifically, paramedic ALS staffing at agency levels have been extremely challenging for a lot of rural communities. They were not being able to fulfill that, maintaining that one paramedic a day. There's all kinds of reasons that go around into it, whether it's not enough pay. The end result was we had agencies reporting that was not meeting current regulation and maintaining that around the clock paramedic staffing. So what the board decided to do was to modify staffing and allow an exemption that you could apply for and to give credit for that advanced EMT operating within that community. So under the emergency, you can apply for a temporary waiver. It requires a pretty significant, it's just not a rubber stamp. You've got to go through a pretty significant process to say, I've got a problem. Here's my next couple of steps over the next year, 2 years. And we want to be able to allow that advanced EMT to suffice for that advanced level so you're not in consistent violation with the regulation. So that is passed. I think currently we've got one granted waiver, and it wouldn't surprise me to see if we don't have a couple more start to float in the next little bit. At the end of the day, paramedic staffing across the Commonwealth in rural services are struggling. It's like you've not ever seen before. So that's why that was put in there. You saw some training and education changes in 23 that addressed just a cleanup of the education platform in general. But probably the biggest thing as we go forward is the board recently adopted the student minimum competencies for your advanced EMT programs. And that's a national registry requirement. We were a little late in adopting them, but what that does is that sets student minimum competencies for advanced EMT programs. Make sure that if you're teaching one, or if your agency's teaching, or if you're a medical director over an education institute, that you see these student minimum competencies and you're following the board recommendations as adopted by the board. And then part of the next big thing is scope of practice document. It's went through several changes throughout the last couple of years. The most recent was adopted in January 7th of this year. So just to make sure everybody understands, especially for you new people, the scope of practice sets the ceiling. Your medical director sets how you operate within those. So just because it's on this document doesn't necessarily mean you can do it without medical direction oversight. So that's really important because we see a lot of complaints come through in disciplinary matters that people sometimes get out of bounds on this scope of practice, and it creates a lot of problems going forward for them. That's kind of what's happened in the past. So here's the kind of things that are pending. These are the things that are in the pipeline. And we talk about the biggest one being the advanced practice paramedic. That's the 410 regulation. I think in probably late 23, they established the advanced paramedic licensure, but it really only addressed wilderness paramedicine and community paramedicine. So that it provided pathways for licensure for those. The new modification adds your other three. It adds tactical paramedic, it adds flight paramedicine, and it adds, somebody help me where I'm missing one. Critical care. Yeah, critical care. So it brings licensure paths for all the other specialties in that regulation. Again, it's currently at the legislation in the regulatory compiler's office, going through all of its legalese to go through. But at the end of the day, like we talked about, it sets that licensure pathway for 2027 transition. It does You got a question? You rip that Band-Aid off quick. So one of the big discussion points when we talked about 14 being so widely discussed is what do you do with current endorsed critical care people that are practicing currently? And there was a lot of debate whether, because ultimately what the advanced practice regulation sets is it's going to set the IBSC certification as their credentialing body before it gets to us. So ultimately, anybody after that 2027 timeframe that wants to get licensure is going to have to present some form of IBSC certification in order for us to license them. So the big discussion come because we really only have two that we really look at. We had current critical care endorsed people, and then we had a small bunch of MIHCP pilot programs. And what the board ended up doing was offering a transition grandfather into that advanced paramedic licensure. But what it does is one, it sets a specific time you've got to make application by. That's why we cut that off in July 30th, 2025. Is at some point we had to say, we're not going to issue endorsements anymore to allow for everybody to start getting those grandfathered in transition. It was nobody won the argument because there was a strong bunch that wanted no IBSC. There was a strong bunch that wanted IBSC. It was kind of if you deal with statute and regulation, it's a give and take. And we think this is probably the best step forward. It ain't perfect. It's not 100%. But in 10 years, are we better off than we are today? And I think that regulation, the way it's written, does that. So that's where your grandfather language. So they will have up until September 30 of 2026 for if you're currently endorsed to make that application and transition. And I know a lot of people are going to say, well, why September 30, 2026? It's a licensing platform software issue that we deal with internally because October 1st, we open renewals and it pulls data off your core license. So if you're not transitioned by then, it creates a licensing nightmare going forward internally. So that was the best process we could do to try to make it a little bit easier and smoother. So ultimately, they will have to make that application by that date. If they don't, they pass that application, they're going to have to get IBSC. They're going to transition over to the new advanced practice. So no, what they adopted was similar to what they do to state licensure now is a continuing education path is. So for those people that want to do it, the continuing education is the same that the IBSC does. 100 hours over 4 years, 100 hours over 4 years. It's just kind of broke out that way in language because we do a 2-year recite cert. So it's a 50 hours over 2 years in core content hours linked to the IBSC. So while you're not necessarily required to be IBSC certified, we are linking them together as best we can to make sure they're getting continuing education hours in that platform. If you're going to operate in the advanced scope of practice model, you're going to have to be certified within that field. I believe you're probably going to be somewhat correct. Way to complicate things, Jamie. Yeah, and Lubbers, you jump in, but if it's going to be our probably interpretation. If you're not adopting advanced scope of practice models, then you're functioning as a paramedic. Yes. No, no, I do not believe that. You need to really hone into the advanced scope of practice models and see what's the differentiations between the two. What you said, no, being a tactical paramedic functioning in a hot or warm zone would not necessarily require this licensure. It's only to function at the advanced scope practice models. So it's probably about it's clear. We're not going to come looking for you. So, so that's the advanced practice. Like I said, it's currently in uh, the regulatory review process at the legislation. It's open for public comment. I'm sure there will be public comment. Like I said, this is probably one of the ones that got a lot of debate, but I think we, as staff, medical director, and the board, felt that this was probably the best compromise and platform to get to the end result. So that's where we're at with it. So the next portion is the 545, and it's going back. I think it just passed the board, the last section, so it'll be filed. But this defines the level of agency licensures across the spectrum. Uh, there was some statute change a couple years ago that required us to do some modification in emergency response, interference. It created a little bit of problems. But what we tried to do is better define who's doing what across the Commonwealth. So currently, if you looked at, we got a bunch of class one agencies. We got 200 or 190 some odd class one agencies. And class one kind of was, well, you could do everything. Well, we know that not all class ones are doing everything. So we started to hone down and say, okay, your class one agencies are going to be responsible for emergency response. And it has a subclass based on some statute that's based on how you get your license. It goes into a class two. And class two are those that are not doing emergency response, but are doing hospital, that we really focused on your hospital bases that are doing transport, convalescent, interfacility, and so forth. Class three stayed the same. You still got your specialty care units doing adult critical care, pediatric, and neonate. They really didn't change. We just added some a little bit more clarified identifiers. Four stayed the same. We'll talk about class five MIH programs here in just a second. Uh, we added some clarity to class six, which is emergency first response, BLS and ALS first response agencies. There was a lot of discussion in how we bring in fire-based systems that are not licensed by the board and providing a little bit clearer path of what's needed, what's not needed. So we tried to clear that up and add some language in there to help streamline that process and make it a little bit clearer for agencies. Class seven is air medical. It stayed the same. Class eight is your event medicine. We added a class nine as we start to look in what the future holds. And what the class nine will be is it's going to be a state recognized special response teams for statewide jurisdiction. Really looking at your USAR teams and things as they start to build up. I believe that USAR team is going to have a medical side component, and we felt best that that these levels of disaster response, like we're seeing in East Kentucky, is to have their own level of licensure so that we can hone in and make sure everybody's covered and in good stance. And then I believe there's a class 10 that talks about reciprocity licensing from out of state. And that's basically as a result of some federal rulings on some CON language and stuff going across the borders. So I've got these other ones that's kind of sitting up there, 501, 550, and 55. Those are all specific to licensing. So when we change the 545, we're going to have to dive in to the 501, the 550, and the 55 to hone in equipment lists, operational requirements, and so forth going with those. 596 is your MIH. It was just posted, so we will begin probably March 1st through the 15th is a good window of opportunity to start to license community paramedic programs. So I think we have a handful of MIH pilot programs. I will anticipate seeing those transition to licensure, and it's its own little beast because MIH is still a new concept. There's still a lot of information that's got to be gathered, but we do have a licensing pathway for them now, and that's been sitting out there for a couple of years, kind of in limbo, but it finally got posted, and we will begin to start taking applications in March. We're just waiting on some internal office application processes to finish. But it outlines everything you need to function and launch a mobile integrated health program within your agency or within your community. So what's next? You know, we would talk about statute regulations. We can only hit statutes only a certain amount of time. We want to amend the block grants. We want to be able to remove red tape and get funding dollars to local agencies a lot easier. When we look at, it's not a lot of money, but it is money. You know, we get 1.2 million to give out across 120 counties. So we want to remove that red tape. And when we look at denials, it was denied because of some unnecessary red tape that really did not impact the overall mission of the go. So we want to be able to streamline it, and then we're hopefully going to go back and try to start to increase that dollar level, make it more meaningful. Agency investigations. During the last one, they pulled agency investigations back to the cabinet. We want to bring those back. I'm going to be frank, it's not working. We're 3 years behind from getting anything from the Cabinet for Health and Family Services, and it's not efficient. We want to bring that back to the experts to where we can streamline and get these cases on agencies closed. Otherwise, they sit out there for a while. Yes. When it comes to agency investigations, yes. And they just don't work well with others. When you call to talk to them, and you're like, how many did you have? Well, we can't tell you. Well, do you have something on so-and-so? No, we're not going to tell you. The working relationship in the upper levels are very strained. They're investigators. They had one, but he quit, and they're having trouble filling it. They're always going to have trouble filling it because agency and provider investigations are a nightmare. Trust me. They're miserable to complete, but we need to bring those back. And I think you'll see some type of push in the near future. I think Lubbers may touch on it a little bit later and talk about medical director qualifications and make it a little bit of change in statute so we can make needed change in regulation. So that's kind of looking at our next ones. Here's some others that are on the forefront. Like I said, that's probably your 501, your 50, and your 55s. So your equipment regulations, your agency operations requirements to get licensed, and some administrative stuff are on the forefront. I think the 801 being medical director. I'll follow Dr. Lubbers sometime in the next day or so to see if we can get working on that draft. It's kind of been in committee for a little bit, and I think we're ready to push on to the next phase, if I'm not mistaken, for a draft anyway, for discussion. You'll see another look at the 560 regulations based on licensure change, on staffing, and then our data reporting requirements. I think that will go a pretty significant undertow of what needs to happen. So for those that wasn't aware, in late 2024 in November, the state underwent a National Highway Traffic Safety Administration nationalized federal EMS reassessment. And we talk about a reassessment is because the initial assessment was done in 1991. In 1991, we were still under the Cabinet for Health and Family Services. So they've been wanting to get back here for a while, and there's been a lot of hiccups along the way of why we didn't. It was scheduled, COVID hit, it was rescheduled, COVID re-hit, and then I got to asking questions on grant funding, and it kept saying, you've got to do this EMS reassessment, or you got to do an EMS assessment. And I'm like, that's pretty broad. Give us some money so I can make sure people are doing assessments. And they're like, no, they want you to do this reassessment. And I'm like, okay, let's do it. And boy, when I tell you, I probably bit off more than I could chew. It was pretty significant. It took about 7 months to compile this long workbook of what we've done since the 1991. What are our shortcomings? What do we need to work on? What's not working? What is working? And it took a lot of people. Obviously, we had all of our internal staff. We had public health. We had Homeland Security. Worked with Dr. Lubbers and medical director group. We had some air medical people, kind of all in the backgrounds working and putting on these 13 different assessment points. And what they did is they wrote back and gave us what their assessment. But the most important thing they gave us was they gave us 55 different recommendations that we as the Commonwealth need to tackle. And it ranged from like 13 or so statutes that need to be changed and somewhere around 47 different regulations. And like I said, it crossed different aspects. It all didn't hit us. I think I saw Dr. Bernard coming later. He was a big player and talked about trauma systems and trauma systems funding. Here's some of the big ones that it kind of sticks out. Is a big talk is how do we improve interfacility transport? And I think Dr. Davidson talked about air medical, and when we see that spike, you're going to see a pretty significant spike correlation in the interfacility and the lack of EMS transport. You know, a lot of these rural communities are relying on air medical because they can't get ground transport because of the staffing shortages. So that is something that the board and us is really going to have to dive in and take a hard look is how do we improve interfacility transport operations within the Commonwealth? They wanted us to codify EMS as an essential service. That's a big lift. You know, you make something statutorily required, well, you got to fund it. That's not going to be an easy task to get through the legislation. We look at, I don't know how many medical directors do we have? How many oversee their EMD dispatching protocols in their dispatch centers? So there's a lot of talk on deleting that emergency medical dispatch qualification for dispatchers. So you need to be aware of that. That's on the forefront. There's a lot of talk. The board just passed a resolution to say, hey, we think that's a bad idea, and this assessment contradicts what you're wanting to do. So they really want us to hone in and require the use of emergency medical dispatch for dispatch centers that are providing 911 response dispatch notification. Their own authority and funding for the board medical advisor. Another one that may be of interest, may not, is develop training for online medical control for physicians. I think when we looked across the Commonwealth of, well, do you have training to be online medical control? There's a lot of questions that kind of lay in that portion. Implement a PAN, we talked about that. Integrated health, again, it wants us to start launching and endorsing the mobile integrated health programs in the rural communities a little bit better to make sure we're getting there. Develop and require state-specific medical director qualification education. And I think Dr. Lubbers is probably going, are you touching on that later? Yeah, I'll let him touch on that specific stuff. But ultimately, it's going to roll out to what kind of education platforms do you think a medical director needs to run an agency and looking at those requirements. And then it talks about changing the board composition. And Again, that's a statute change, and it's going to require a lot of discussion. But it had improved diversity in geographic representation, and it also wanted to make a recommendation of adding a trauma surgeon back to the board. So some of these things are easy, most of them are hard, and it's going to take a lot of time and a lot of effort. But the big thing is, as the medical director, I just want to, some of the common things we're seeing is you all set the standard within your agency. And if you don't want working license, you have broad authority to say, no, you're not working under my license. It don't require a lot. It's not going to require a lot from the board. We're seeing a lot of stuff hit the board level in disciplinary matters that are much easier handled at the local agency. We want you all to be the first step in saying, no, you're not doing this. Provide whatever level of disciplinary action you want. You have that authority, and then make the reports of employee A did X. Here's what we did. Do you all have issue with it? That's what we want. We want it all kind of pushed back to the lower, because we've got a backlog. I think we're working. Shoot, I still think we've probably got 20 or 30 provider level investigations that we've got to get caught up on. And they keep coming in every day. And a lot of the stuff can be handled a lot easier at the local level. So please don't hesitate. We want you all to take care of business within your agency, and don't wait on us to guide you in the disciplinary process. I'll open it up for questions. Yeah, come on, Dan, I got you. That's okay. Uh, so I think what actually we could take, what we can do is the board can revoke your authority to function as a medical director. That's listed in regulation. That, and Dr. Crafton, speak up. Uh, if we get a complaint on a medical director, then it goes to the board, and the board can say, we're going to revoke your authority to function as a medical director. And that's given to them through regulation. Okay. Oh, absolutely. Yes. Well, since I've been there, I'm on. We went through a significant overhaul. So over the last 2 years, our entire platform of administrative staff has changed. So since I've been there, no. Uh, Again, that's the authority of a local medical director to say, we don't usually dabble into that. That is a agency specific. Say it again. Absolutely, and that's what we want you to do. You all deal with them on a daily basis, and if you find cause to not authorize them, that is your authority. That is your right as a medical director for that agency. Go ahead. You good? Oh, okay. Nothing else? Hey, that was easy. Um, let's see.